Dear friends, I'm Dr. Alex Guo-Hao, periodontist at the University of California, San Francisco. I'm honored to introduce my co-author, Dr. Joseph Kane, prosthodontist at Loma Linda University. Our AAP consensus paper explored how different prosthetic designs affect marginal bone loss around dental implants. In our paper, it shows less bone loss with the cement-retained versus screw-retained crowns. What is your opinion on this topic, Joe?
So first of all, thank you, Alex and AP. I want to make a comment. Anytime when we compare bone loss, first of all, you know that as a researcher, it is so difficult to do a study to consistently measure bone loss, from one X-ray to another, especially periapical films, and despite how we calibrate. So therefore, there's always a margin of error when we measure bone loss. So, clinical reality is this, from a prosthodontic standpoint, definitely a little bit more problems with cement retain, versus screw retain. And most clinicians actually, they prefer nowadays to restore cases with the screw retain. Not only is less expensive, but we don't need to deal with the dreadful cement. So when we look at those studies, another point that I want to bring out is, with the inclusion criteria, in the end, there's only a limited of studies, that we're looking at. And and a lot of those people who publish those papers, if you look at the name, they are pretty well-known names. So I'm sure in their study, when they are probably extra careful in cleaning cements and things like that, and the prosthetic design is probably more appropriate. So with that in mind, I'm sure that's part of the reason why you don't see any difference. But for sure, if you use cement retain restoration, Alex, there's always a risk of cement being residual cement. And now, doesn't mean that every time when there's residual cement, we will always lead to bone loss and or peri-implantitis, but the risk is higher for sure.
Yeah, thank you for that comment. Yeah, in our paper, the analysis also showed that the non-splinted individual crowns had a slightly less marginal bone loss compared to the ones that are splinted together. I know this is a very interesting topic. So Joe, can you share your experience with us?
Oh, absolutely. Well, I mean, in my opinion, from a restorative dentist standpoint, it's always better to do individual crowns, single crowns, non-splinted. Why? From a hygiene standpoint, maintenance-wise, is a lot more simpler for the patient. However, on the other hand, splinting restoration sometimes will, some people believe that in situation that especially maybe the bone is somewhat compromised or the implant length is a little bit not as optimal as we want it to be, by splinting, it may strengthen up the whole system there. So, and then also from a resources standpoint, sometimes, placement of splinting restorations, because of the lack of interproximal contact we need to deal with, the restorative dentist is actually happier, because it's less work. But in general, I mean, this part, clinically, I totally agree. Splinting, harder to maintain hygiene, potential increase of greater risk of bone loss. However, but even if you look at those data on the paper, the amount of bone loss, those significant comparing splinting individual. But clinically, I think it's less than 0.5 millimeters, if I remember right. So it's correct. Not like a huge amount too. So I want the clinician out there to understand that, I mean, if they really need to splint a restoration, don't panic, I mean, as long as the design of prosthetic is so important, for maintenance and teaching the patients how to maintain. I think that is probably the bigger key than just focusing on whether we should absolutely splint or doing individual restorations.
Yeah, that is a great point, especially that we always need to make sure that we have a great hygiene access after we deliver the restoration. And that's probably the most important thing.
I think so.
So let's talk about the platform switching. Our review also confirmed that platform switching abutments result in less the marginal bone loss compared to platform match designs. So what's your thoughts on this?
Well, Alex, as you know, I believe almost all implant systems nowadays, modern day implant system, are pretty much platform switching. And but then again, if you look at the previous implant system, there's platform matching. Clinically, I'm sure at your university, you have a long-term follow-up. A lot of those cases do look amazing. Okay, so platform switching is I think from a theory standpoint, it bring it bring that gap, the gap between the implant platform and the prosthetics components invert away from the bone, shielding away from bone. So from a conceptual standpoint, that bring the bacterial wall that's being formed by the gap away from the bone. So it kind of makes sense that that it will minimize bone loss. In fact, study has shown that the greater the mismatch, all right, the greater the mismatch seems to be even more advantageous in terms of maintaining the bone. So I think that is pretty clear. I don't think, on the other hand, I don't think as a clinician, we don't have much choice nowadays. Almost everything is platform switching. So, but the good thing is, seems like we're heading the right direction. So I do like that idea there. Yeah.
Yeah, thank you. Yeah, I agree with you. Most of the bone level implants that we are able to restore, they already almost have the built-in platform switch design. So that's pretty much the right direction that we are heading toward too. How about abutment height? The data in our paper showed that the abutment height with height of 2 millimeters or more, this kind of design is more protective against bone loss. What do you see clinically?
Well, that in a sense it makes sense, okay, but it's also like a double-edged sword. Why? Because the good thing is when you bring the margin of the abutment closer to the and I'm referring to a one-piece type of prosthesis. Okay, so anytime when there's some sort of abutment or you have a titanium base, that's what we're referring to. So it makes sense to bring the margin away from where closer to where the bone is. By doing that, it probably, from 3D standpoint, it should help to minimize the bone change. I remember that on our paper, the difference is around 0.3 millimeters or something like that. Again, not a huge difference there. However, and also if you bring the margin or the abutment higher, greater than 2 millimeters, and that will usually leave the margin around 1 millimeter subgingivally. By doing that, if it's a cement retained restoration, it also will help to facilitate cement removal too. So there's a lot of advantage to it. So what's the other side of the story, especially for the restorative dentists? Sometimes when we bring the abutment too high, but those abutments are usually prefabricated, to a great degree. The emergence profile may not be, as conducive for the aesthetic environment. For the posterior implant, it's pretty straightforward, but in the aesthetic zone, sometimes people want things a little bit more customized. As you know, they want different zones with different contour. I remember you published a paper with Stephen Chu, right? We talk about the contour, emergence contour, and so sometimes that part will help. Something a little bit more customized will give a little bit more leeway for the aesthetic standpoint, and also by putting a margin 2 millimeters above the implant platform, and in some situation, especially when the peri-implant mucosa is not as high as we want it to be. So any minimal recession sometimes, especially if it's a titanium-based abutment, will create some sort of aesthetic crisis too. So, and yeah, I think it makes sense to have the abutment a little bit higher. I'm not sure that whether we really need to use that exact 2 millimeters as a demarcation line, but it makes sense to put the abutment a little bit further away from the bone. I would say that at least 1 millimeter above that will be probably a good number to start, in my opinion.
Yeah, thank you, Joe. I know most of the papers that we included talking about 2 millimeters as the cutoff point. But like you said, we don't really know if that's for sure a set number or there could be some leeway, or is it longer the better? So I know that even for most of the companies, they have 3-4 millimeters long abutment. So we still don't know if there's a threshold that if you go longer, if everything's gonna get better. And if you go longer, you have to place implant deeper as well.
That is a great point. And when it's placed deeper, so what are the consequences, right? I mean, yes, nowadays there's a tendency wanting to put the surgeons put implant a little bit deeper, but if the abutment is 4 millimeter deep, then you may need to put the implant 2 2 to 2.5 millimeters subcrestally. And can that bone really truly sustain between the implant abutment interface over time? That's another question. And if it doesn't, so what happens is it creates almost like a little bony crater, right? I mean, and then you're a periodontist, so if you have a little bony crater around a natural tooth, what do? Are you happy about it? I mean, it increases the risk. So those are things that we always do balance it out.
Yeah, I think there's always something that we need to take carefully from the paper. Even we talk about 2 millimeters, but there could be another threshold, not really the longer the better. Joe, you also talk about the emergence contour. So I think this is a good, like a side way to think about and talk about this topic. So we know that emergence profile, emergence angle, this is an area getting a lot of attention lately. So similar to other cross-sectional studies, we found that a convex emergence profile and a wide emergence angle are associated with higher risk of peri-implantitis. So what is your opinion on these two emergence contours, profile and angle?
That is a great point. I think over the last probably 6, 7 years or so, clinicians are increasingly, at least from an academic standpoint, focusing a lot more about the contour and profile because they believe that that can affect the bone or marginal bony changes. However, I'm trying to remember that paper we reference based on that 2 papers, right? I think the Kawaguchi's paper and Ye's paper, and because of the inclusion criteria, a lot of other papers doesn't fit in there. So how, of course, both papers significantly show significant greater amount of peri-implantitis and bone loss. So, but both papers, were they mostly focusing on anterior or posterior region or everywhere? Do you remember that?
So it's everywhere.
Everywhere. Okay. So, I mean, so the 2 factors, emergence profile. I think in my experience clinically, and also, we are doing some research work on that too. A convex, emergence profile definitely potentially increase the risk. And if you compare emergence profile and emergence angle, the convex emergence profile is probably by far, in my opinion, a more dominating risk than the emergence angle. And so in emergence angle standpoint, the authors keep repeating using the term, I think, 30°. The funny thing is this, I mean, is that really an absolute number? I'm sure. Just like, again, we go back to talk about that 2 millimeter abutment height, is that the number? So I guess the message we want to send it to the community is, I mean, when the emergence angle is really great, I mean, it's probably a little bit harder for hygiene. I mean, so it's just common sense. But is that like an absolute number? I'm not sure, because if you think about it, Alex, when we place implant in the aesthetic zone, okay, and by the way, both of those papers, they only look at the mesial distal aspect of the crown, right? I mean, just think in an aesthetic zone, a single implant crown, let's say, a lot of times surgeons are trained to place the implant a little bit more palatally, right? So, and you have around 3 millimeters of so-called prosthetic running room. Inevitably, that facial emergence angle is going to be already close to maybe more than 25 to 30°. And so I'm not sure that, I think this is something that we need to be aware of, try to make prosthetic design. I'm not sure the number really is just hold the absolute key. I don't think we should get stuck with the number just like the abutment height. But we need to be aware that we want to create a prosthetic that is easy to clean and maintain. And one more point I want to point out is this. I mean, Alex, you're a surgeon. So what happens if the surgeon places an implant not quite at the optimal position? Will that affect emergence angle and emergence profile too?
100% for sure.
100%. So sometimes the restorative dentists or the prosthodontists are being, they sometimes have no choice, right? I mean, they're being bound. So what type of situation? Again, we refer back to that paper you published with Steve Chu, right? So if the implant prosthetic platform is, implants a lot smaller than the implant crown, okay? So unless the implants are placed really deep, you have no choice but to flare it out. Or implants are placed more buccolingual, mesial-distally, that plays a role. So, and so 2 messages I want to send it to the committee. Number one is, I mean, it's not just for the restorative dentist, but the surgeon need to be really pay attention to do what you call prosthetic-driven surgery, right? With that in mind, that will minimize the chance. And of course, from a restorative standpoint, uh, we just need to train our technician that stay away from those, convex profile and try to minimize it. And but last but not least, a lot of these patients, if you have a patient, even sometimes prosthetic design is a little bit compromised. What happens if that patients, in that particular office, that office are really strict on their maintenance therapy? We call the patient every, let's say, 6 months to a year, okay? A really wonderful perio office. And we know by looking at the classical perio literature, even, long span fixed bridges with periodontal prosthesis, right? And then if you come back, check occlusion with good therapy, plus, keep reminding patients on all the importance of home care, a lot of times that also minimize those problems too. Yeah, that's my 2 cents on that.
Yeah, I think it's a very interesting topic, and I know there are more and more studies focusing on this area. Like you said, we don't really know if that 30 degree is gold standard cutoff point. I know most studies from Europe, Switzerland, they look into even 40 degree has been proposed to be the new threshold. So I think that we needed to be careful about all the numbers that have been out there, and sometimes we need to really use our clinical judgment before really applying that kind of knowledge. And I
But
also,
Alex, I want to, since you're talking about that, I think that's very interesting. I mean, you guys, you and your colleague did collect all the articles to review them, right? I mean,
yes.
there are certain articles out there also look at similar type of situations, but also did not prove that I think a greater than 30 degree emergence angle resulted in either great amount of peri-implantitis too, right? I mean, so why do you think that's the case? I mean, and of course, because those articles did not fit within the inclusion criteria, or because they have been published a little bit past the cutoff time. That's why that. But when you look at those articles, why do you think those articles did not show any? Some articles actually tell the different story. Why do you think that's the case?
I think the inclusion criteria for each article is quite different, especially for the Europe articles. They focus more on the anterior segment instead of including the premolars and the molars. So different two sides. It's almost like a biological with supracrestal tissue attachment. Different location might have a different number, but we needed to understand that 30 degree or 40 degree, that's just an average. But different sites, we needed to respect a different specific number in the future. But that is still under investigation. And during our review process, we were not able to include all the study, like you said, because of our preset inclusion exclusion criteria, or some articles that we identified, they were actually published after the manuscript has been accepted. But I do encourage everyone going back to read more like a newer research, like you said, Joe.
But as you know, I'm in the midst of doing a study, looking at this issue there. I mean, and I'll tell you, my data is a little bit different from this the Kawaguchi and Yeast paper too. So what I did was I separate the anterior and the posterior, so two separate groups, and of course looking at all the emergence profile and emergence angle. And funny thing is, like in our to be published material for the anterior group, the prevalence of peri-implantitis is only around less than 5%. Okay, but the caveat is this: when we measure the facial emergence angle, the mean facial emergence angle for those over 100 sample size, and I think over almost 5 years, mean of 5 years follow-up, the emergence profile on the facial emergence angle is mean, if I remember right, it's like 29 degree. And then yet only 5%. But then compared to posterior, we saw a different story too, Alex. I mean, the risk of peri-implantitis or the prevalence based on that, our study is, I think if I remember right, around almost 13%. Okay, so 2.5 times more, 13 to 14%. And then we find out that there's a slightly greater correlation on the on the effect on the emergence, a negative, an unfavorable emergence profile, emergence angle had on the emergence, the periimplantitis posteriorly. So I think we still need to do a lot more study on this matter to really confirm, but this is a starting point. Make the readers aware that, okay, emergence profile angle, pay attention, let the lab know to design it so it's cleansable.
Yeah, that is for sure a very exciting study that you are doing, and hopefully that we could see the results and your study findings really soon in the future. So now let's go to another topic that has been discussed quite a lot, which is the one abutment one time protocol. So in our paper, we also found that using this approach was able to reduce the marginal bone loss around dental implants. So Joe, what's your take on this one abutment one time protocol?
Okay, so I think this is from a pure science standpoint, it makes sense because if you look at the classical article by Abramson, right? Remember, they and disconnect the abutment multiple times versus no disconnection. So the thinking process is by disturbing the bone prosthetic interface, that then you can affect potentially the supercrestal fibers around the implants and may induce a little bit more bone loss. But again, even if we look at the one abutment one time thing, I think the difference, if I remember right on your paper, the difference around less than 0.2, 0.5 millimeters, probably 0.22 if I remember right? So yes. So clinically, all these things are good for, like academic discussion, but clinically is, so I guess I want to make sure the reader or the audience here understand that if he or she doesn't do a one abutment one time in practice, you're not going to have so much problems that it is going to fail, okay? But on the other hand, from a pure science standpoint, based on within the limits of that 10 articles that was included, yes, by leaving the abutment in there during the time of the surgery, without disturbing the peri-implant mucosa, will have a very slightly, favorable peri-implant bone maintenance there. So, but then on the other hand, one abutment one time, a lot of implant systems, do not really truly advocate that. A lot of systems, they don't have that design. Some implant companies probably push it more than the other. So what is the drawback of one abutment one time? The drawback is, again, just like the 2 millimeter height abutment, right? So when you install the definitive abutment at the time of surgery, especially in the aesthetic zone, okay, any peri-implant mucosa migration negatively potentially will expose that margin too, right? And then on top, another thing to consider is this: most of those abutments are designed to be pretty straight up. Okay, so when you bring again, when you in conjunction with that 2 millimeters high abutment, then suddenly the emergence angle you can visualize a lot of times can be exaggerated too. So in my practice, practically, I give you my 2 cents. I do most of my implant restorations are one abutment 12 times.
Okay.
Sometimes for aesthetic, I gotta change the color, change the contact. Sometimes just the contact, it open a little bit more. I need to remove it and fire again. So, but and not that I'm any more better than anyone, but my clinical results radiographically is not really, having massive amount of problems. So to conclude, this is my point. I think the paper, again, give people, clinician, a guideline that, okay, one abutment one time is better, but the numbers clinically, remember 0.22. I want everybody to remember 0.22. 0.22 is not really that big of a number. So either way, it will work. So whatever you're doing out there, the audience, if you feel comfortable one way, I don't think it's significant for you to move the needle to change it, but keep that in your mind, maybe less disturbance, maybe tiny little bit better. That's where I stand on that.
Thank you, Joe. It is great for you to share your clinical experience with us because I know a lot of people, like you said, they are very unsure. Oh, should I switch my protocol in my office just because evidence suggests so? But as you said, even there was a statistical significance, it might not be clinically really, really significant. And like you said, a lot of time it's very difficult to predetermine the final crown contour and the margin just at the time of surgery. We need to respect the healing process and potentially customize the final crown margin abutment, the junction based on the tissue result, especially for the aesthetic zone. So that's really reassuring from your experience. So the next topic, do you think there are other prosthetic design concepts that deserve more attention in the future?
Well, I think, okay, prosthetic, sometimes in academia, we like to make things a little bit more like 0.2 million is a big, big thing, okay? But clinically, it doesn't change the equation. So I think the most important thing, in my opinion, is over the last, 10, 15 years, one of the very interesting design that came out is what they call the angle channel abutment, right? I mean, I believe almost all implant companies have that, or even off-brand, they have that. So what that means is this: it does allow the surgeon, give the surgeon a tiny bit more leeway that, or maybe when the bone is not quite ideal, we can put implant a little bit off angle and we can change that. So I think that is something that definitely will help, to change the equation a little bit there like that. But despite that, I still want to warn the audience that if you're the surgeon, despite with this little backup leeway called ASC, we still need to try to put the implant close to where the prosthetic-driven position is, because that will affect the emergence profile, and emergence angle. But I found that is a very interesting development, out of everything. What do you think? I mean, as a surgeon, I mean, does that really help your restorative dentist? I mean, I'm sure even an expert surgeon like you, sometimes maybe implant cannot be absolutely at the right position, right? I mean, so, how do you, manage it? I mean,
I do think the angulated screw channel, this type of AAC design, from the surgical standpoint, it helps us to potentially making our implant angulation more fitting where the bone is. Because we know a lot of time the bone is not really in line with where we want the restorative position is. So sometimes the bone is really abundant on the buccal side. However, you want the implant to be restored in a more class 2 deep bite situation, then it would not really in line with each other. However, with the angulated screw channel, the potentially 15, 25, I know different companies have different design right now. It will help us to potentially put the implant into where the bone is, and in the end, it would help us to really get into still a screw retained crown. However, with our experience now in the clinic, we realize that we need to be very careful. Angulated screw channel is not something that we compensate, that when we place implant male positioned to buckle, something that we can correct the implant back to the screw retained location. Because if we don't really respect the biological principle, like we need to make sure that the bone at the buccal side 1.5 to 2 millimeters. If we don't really have that, even with the angulated screw channel, we will still see complications. We will still see recessions. So angulated screw channel is not something we use to compensate our male positioned implant. It should be something that's more pre-planned, that we want to make sure that we have a little bit more allowance on the bone in relation to the pros-driven implant location. But we shouldn't really compromise our biological principle, even with the presence of angulated screw channel.
And on our paper, one interesting thing, one of the conclusion was when we compare the external versus internal, connections. I mean, I think it shows that internal has a little bit better bone maintenance, right? I mean, I have my point on that. A lot of times I found that very interesting that on the paper, right, you discuss about, the internal, whether it's a straight connection versus more like a taper, Morris taper or conical, it makes a difference. So it's more, so I guess the point is, are we telling the audience that, okay, internal, it's better to use internal connection nowadays with a taper design? Is that something that you see it make a big difference? What do you think, Alex?
I think in the paper, we did see the internal design has a little bit less bone loss, bone remodeling compared to external connection. And I know that it may not be a fair comparison, especially most of the time the external connections were used for more full arch situation compared to the internal connection we use more for the single unit or bridge situation.
And
So
that's a great point. I mean, the audience need to understand that. I mean, we can have all these fancy connections, right? The more taper, the more conical, press fit or whatever. But once you're in a full arch situation, unless the implants are absolutely parallel, if you ever, as a result dentist, if you ever try to deliver a full arch, with all internal connection and wedge in there, it's not sitting down. So, and not only that, even in a multiple, let's say the clinician is doing a 3-unit or 4-unit, fixed dental implant prosthesis with 2 implants, and the clinician used non-index abutments on both implants, then I'm sure the leakage is much more worse than it will take it automatically into the internal straight situation, right? So a lot of these things are good to talk about, but fortunately, despite it all, it's not as if by doing so, that means non-indexing. We have a lot of failures too, but that is something, like food for thought. And then if you look at the numbers again, I think the difference is less than 0.5 millimeters. I think it's like, again, 0.2.
yeah, that is correct. Very, very like a small margin between the internal and external connections.
Yeah, that's why I tell my graduate student every time when they take board exam, when on any systematic review, if the board examiner asks them, what's the difference between the two groups, what do you know? And if they're not sure, always say 0.2. And probably the chances we're probably correct are really high under most circumstances. Yeah.
Yeah, I completely agree. I mean, another important gap is understanding really how prosthetic designs interact with implant positioning and patient level risk factors. Like you commented before, a lot of times we have to use this type of the compromised prosthetic designs or compensation because implant positions are not really in an ideal position. So we need to understand that these two kind of go hand in hand, that if you have a male position dental implant or non-ideal implant placement, a lot of the time we have to really compromise the prosthetic designs. And it's actually a compensation for the non-ideal implant positioning, not really just the restorative dentist kind of forced mandatory to do that kind of design in order to compensate for the male position dental implant. So it's a ripple effect that increases the risk of the peri-implant bone loss. And we know we all need to keep that in mind.
I mean, excellent point. Patient home care, right? The prosthetic design, cleansability, and of course, occlusion, check occlusion. There's so many variables, Alex, actually. Sometimes putting together a systematic review as just like this one here. I mean, the reader need to be always remember, yes, we're here to select certain variables, try to identify so-called risk factors. However, I mean, what leads to bone loss and peri-implantitis, I mean, is actually so multifactorial, right? Even the patient's own innate response play a role. So yeah, but at least I think the nice thing, in my opinion, on paper like this is give some clinician and guideline. And especially maybe young graduate student as they're developing, say, okay, I know this is the direction, what is going on there. And hopefully that will help them to become better clinicians and minimize problems as they develop the case.
Yeah, that is very, very well said. I think that's a perfect way to wrap up this lecture, like this conversation between you and me. So thank you all for your interest in our paper.
Yeah. I mean, everybody is really special, and thank you for AAP and of course the AO for putting this consensus together, and of course Alex being the lead author. And hopefully this session will guide you guys and give you guys some ideas to become serve our patient a little bit better.
Thank you, everyone.
Thank you.